Good evening, everyone. We are welcome to UroMET Season 2, 2.2. Today, we are going to discuss urothelial cancers, including bladder and upper tract. Bit of housekeeping I want to introduce before starting. Today's session, we have 4 talks by 4 senior registrars. And we have 2 expertise on board, Dr. Manjula Herath and Dr. Ranga Vikramarachi. So we have at least 20 to 25 minutes of talk, and after that we'll have 7 to 8 minutes or maybe 10 minutes of discussion and the clinical scenario as well as comments. So to start this session, I'll invite Dr. Mohammed Nabil to talk on core topics of urothelial cancer as well as evaluation of hematuria. Dr. Nabil, you will have 20 minutes, and prior to 5 minutes, we will give you an alarm. Over to you, Nabil.
Okay, thank you, sir. Can you hear me, sir?
Yeah.
Can you hear me?
Yeah, loud and clear.
Yeah. So I can I say my screen? Can you see my slides?
No.
Not yet.
No, not yet.
Okay.
No.
I have shared my slides.
Not yet, Nabil. We can't see your slides.
I can see it's it is upload. I can see the slide view. So it is in the slide mode. I have shared the screen. So is there any other? Yes, share the screen. I can see my my topics in the presentation view.
You share the screen and go and select the particular view that you want to select, slide.
Yeah, I have selected the presenter's view, and I have selected the slide, which is I'm going to present at the moment. Now I'm in a Zoom.
Can you share your screen, Nabil?
Broadcasting, yes. Just wait for that. Sorry for the delay. It's
No worries.
sharing. Yeah, it's sharing. At the moment, says I'm sharing.
Now.
Now better.
Now we can see, but your voice is not clear.
Screen. Can you hear me?
Yeah, now better.
No, better.
Probably wait. Just go off. Can you hear the sound now? Can you hear now?
Yeah,
Yeah.
now
Yes,
it's
please.
better. Yeah.
Yeah. Then slide also can be seen, no?
Yes.
Yes. Okay. Yeah. Good evening, everybody. Just sorry for the delay. And today my topic is urothelial cancer core topic and the evaluation of hematuria. I'm a senior registrar from Kennedy Teaching Hospital, Dr. Nabil. And the first I will consider for the evaluation of hematuria. The hematuria, while introduction, the presence of red blood cells in the urine is considered as a hematuria, where it may be a visible or non-visible hematuria. So it can present in the isolation, or it may be present with the symptoms. Like sometimes it's called asymptomatic or symptomatic hematuria clinically. The microscopically, it is a macroscopic or microscopic hematuria. So one of the commonest reason for the urological referral is in the UK, there are around 1 lakh hematuria referral for GP in the UK for a year. Evaluation of this patient should be clearly targeted toward the excluding underlying urological malignancy. That is our aim. So according to the visibility and timing of the urine during the urinary system, it can be classified. The gross hematuria can be classified in the initial and terminal and total throughout the stream. Where the microscopic hematuria, it can be asymptomatic and symptomatic. So when you consider the microscopic hematuria, the elaboration where The presence of 3 or more red cells per high power field in centrifuge resuspended urine sample is considered as microscopic hematuria in some guidelines, some 2. But in the dipstick test, sometimes it may take more than that, is a higher number. But is ideally the guideline says 3 or more red blood cells in the per high power field. So it can be classified in a symptomatic or asymptomatic. But symptomatic means it may be associated with bloods or associated with pain, and so asymptomatic without pain and blood symptoms. So presence of non-visible hematuria, there is no clear-cut demarcation percentages. It ranges from the 2.4% to 31.4% in different studies, where 2.6% with non-visible hematuria will have an underlying urological malignancy. When we consider about the causes of the hematuria, it can be nephrological and the urological causes. And where the nephrological around 10% on total of 100 patients, where the urological more around 30%, where nephrologically, I can give the list of examples, finding diagnosis are there, where it may be associated with glomerulonephritis, primary or secondary, and familial condition like polycystic kidney disease and Alport syndrome like examples, and exercise-induced and vascular causes and metabolic causes like and papillary necrosis are some are drug-induced. And urologically, where we can be considered as a benign and malignant lesion, where malignant lesion from the renal cell carcinoma to up to the urothelial carcinoma and prostate cancer. Where it may be a benign condition like UTIN, urolithiasis, and even BPH and trauma things can be caused the hematuria as a benign causes. So most of them, some are after all the evaluation, some are even non-diagnostic. Even 60% of the people have a hematuria evaluation will have a non-diagnostic. And when we consider about the comparison of the guideline, while evaluation of mainly the AUA and Canadian and NICE guideline comparison I have taken in from the BJU UI, and where the difference guidelines say according to the number of red cells according to the microscopic hematuria, something different in Canadian 2 RBC, some from the American Neurological Association as well as and the NICE guideline. NICE guideline mainly positive for the dipstick. Mainly it takes more number of RBC needed to dipstick to be positive. But others mainly usually 3 is the recommended number of red cells where we are assessing as a microscopic hematuria. And indication for evaluation where the mainly the all the gross hematuria has to be evaluated, and where the non-visible hematuria in difference are mainly some guidelines, some second when initial episodes are not taken into consideration, the repeated persistent hematuria are considered to for a second episode hematuria is considered to evaluate the hematuria. And where the baseline test for all, where it takes all the basic investigation, the renal function and the UFR, where the assessing the nephrological causes for the renal urinary cast and RBC cells assessment, where the nephrological causes to be for the evaluation. When all the consideration of all guidelines, nephrology referral, mainly some in the NICE guideline where it mainly takes younger than 40 years. Usually they don't have, if the nephrology cause is the reason, they more not evaluating the urological causes completely. But in other guidelines, usually they say to complete evaluation even though there are nephrological causes has to be found. And so main consideration about the NICE guideline where the referral, where they have more than 60 years, they are recommending urology referral where visible hematuria, and more than 40 years they are recommending. And other guideline more towards 35, and in the AUA and Canadian, and where Danish guideline they are more than 50 a year of age. And where the when considering about the NICE guideline, they have a more radiological evaluation. They are mainly no definitive recommendation, but CT urogram they are considering from the CT urogram they are considered in the evaluation, but no definitive recommendation. Canadian mainly ultrasound scan as a baseline recommendation, So usually all other guidelines are recommending the according to the risk category, and ultrasound and the CT urograms are considered as a first line radiological evaluation. So all the visible hematuria, cystoscopy are considering all the guidelines. And non-visible hematurias, they are recommending according to the persistency and the risk groups, they are recommending in a different way. In a NICE guide only, they are recommending DRE and PSC in a visible hematuria in the main. But other guidelines are not recommending in the evaluation of hematuria as a PSC as a test, initial evaluation. So these are the main differences when I consider it for the evaluation of hematuria. This is a diagram what I have described at the moment in a different way with a comparison way. This is a asymmetric hematuria evaluation according to the American Urological Association guideline, which recommending the history examination after that renal function test, an imaging modality, and if a follow and then follow up in at least urine analysis and micro yearly of at least 2 years, and really if it is negative for 2 years, then release from the care. Likewise, if there is any unable to go CTU, they are considered for the imaging of the optional images, and concurrent nephrologic workup has to be done if there is any nephrological cause has to be found. Likewise, the evaluation has to be there in the asymptomatic hematuria. So this is a total algorithm where I have gone through the UTI as well as urolithiasis combination altogether. While evaluating the clinical, while evaluating the hematuria, initially if the hematuria is there where it is urolithiasis found. So if yes, we have workup for the urolithiasis more young patient. But if symptoms of UTI, we treat for the UTI and repeat the UFR for the microscopic hematuria evaluation. And if the visible hematuria, likewise, all the patients what I have already told, we have go through the evaluation of hematuria evaluation path. This is a summary of the hematuria evaluation. So ultimately, I come to the recommendation where the patient meeting criteria for evaluation, complete evaluation, even one phase of evaluation shows suspected cause of microscopic hematuria. If medical cause for renal hematuria is suspected based on the presence of renal insufficiency and hypertension and abnormalities of urine analysis, nephrology evaluation is recommended, but the patient should still undergo a urologic evaluation. Cystoscopy should be performed in all adults who meet criteria for hematuria evaluation who are 35 years of age and older. And cystoscopy may be omitted in a patient younger than 35 years without risk factors or clinical suspicion of bladder cancer. AUA guidelines still recommends against blue light cystoscopy for evaluation of microscopic hematuria, and multibasic computer tomography where CT is recommended imaged by the AUA guideline for the evaluation of asymptomatic microscopic hematuria. None of the available urinary biomarkers are not recommended by most of the organization in initial evaluation of patient with asymptomatic microscopic hematuria. And cytologic examination may be considered in all patients with negative initial workup, in whom urological carcinoma is still suspected, as well as in the patient with symptomatic microscopic hematuria. So in the near future, the studies are going on for the evaluation of the bladder cancer, where the urinary molecular markers are considered to the evaluation of hematuria in a few studies trials which are going on. It is taken for the diagnosing in a hematuria evaluation, diagnosing a new bladder carcinoma with associated with the cystoscopy, as well as recurrences identification of the hematuria, while recurrence identification of the bladder cancers. These are studies ongoing trials. And as a summary, history and physical examination, the renal function testing, and upper urinary tract imaging for all patients. And what I have already told up to now is the initial part. White light cystoscopy is recommended in evaluation of asymptomatic microscopic hematuria, and CT urogram is preferred imaging modality for evaluation of hematuria. Urinary cytologic examination biomarkers are not considered initial evaluation of asymptomatic microscopic hematuria. And patient with negative complete evaluation can be released from care if subsequent neural analysis confirm resolution of microscopic hematuria. Re-evaluation should be considered in all patients with persistent or recurrent microscopic hematuria in those with incomplete initial evaluation. So next, my topic is urothelial carcinoma, where I have taken into the epithelial introduction as a epithelial lining is defined of the mucosal surface of the renal collecting tubule and calyces and pelvis, as well as the ureter and bladder and urethra, is where the term urothelium is refers to these surfaces. The upper tract urothelial carcinoma is rare subsequent of urothelial cancers with poor prognosis. Urinary bladder cancer is the most common malignancy involved in the urinary system. When we consider about the epidemiology, urothelial cancers are the 6 most common tumors in the developed countries. They can be located in lower and bladder urethra as well as upper pelvic urinary tract. And bladder tumors account for around 90 to 95 urothelial carcinoma are the most common urinary tract malignancy. Bladder cancer is 7th most commonly diagnosed cancer in the male population worldwide. And there are statistics worldwide age standardized incidence rate is around 9.5 for men and 2.5 for women. It's a 4:1 ratio. In the European Union, age standard incidence is around 20 men for the 4.6 for the woman. And approximately 75% with the bladder cancer present with the disease confined to the mucosa, mainly and submucosa. Sri Lankan Cancer Registry, where 2009 is the age standard incident rates in the urinary bladder cancers in Sri Lanka up to 2005 to 2019, where the incidences goes up to the 2016, somewhat incidence is less in the latter part of the 2000 up to 2019, 17, 18, 19, even the male and female ratio. But age group when considered, its incidence is increased from the age group from the 35 years onwards, it is increasing more toward up to 35, 75, and more than that, it is increasing the incidence, age specific. So I have taken into the different upper tract urothelial cancer and separate incidents. So those are uncommon and 5 to 10% of urothelial carcinoma, and pelvic calyceal system twice as common as the ureter, and similar morphology to bladder cancer, where the chances of having a bladder urothelial carcinoma is 30% when there is upper urothelial carcinoma. Chance of having a upper tract urothelial carcinoma is 6% in the bladder urothelial carcinoma. If the recurrence occurs, it tends to occur more in the bladder rather than the contralateral urothelial carcinoma. At diagnosis, 60% of invasive compared to bladder, up to 25 is the only invasive carcinoma in the bladder. So male to female ratio is 3:1. When we consider about the bladder carcinoma, already I have these things I have explained. The 5-year, mainly the 5-year survival is 53% overall bladder carcinoma. 10-year survival is around 50%. The primary urethral carcinomas are very rare and well less than 1% of genital malignancies, and the number of incidents also is even in the European Union countries. The etiology when considers the tobacco smoke is the most important risk factor for the bladder carcinoma, about around 50%. Main positive things is considered as aromatic amines and polycystic hydrocarbons, which are renally excreted from the tobacco smoke. And occupational exposure is to aromatic amines and polycystic aromatic hydrocarbons and chlorinated hydrocarbons is the second most important risk factor for bladder carcinoma, accounting for about 10% of all cases. So mainly occupational exposure occurs mainly in the industrial plants which process paint and dye and metal and petroleum products. Recently, great occupational exposure to diesel exhaust has been suggested as a significant risk factor. So family history seems to be a little impact, and no overt significance of any genetic variation of bladder carcinoma has been shown. And dietary habits seem to have a limited impact. And the chlorinated drinking water and subsequent level of trihalomethanes are potentially carcinogenic. Also, exposure to arsenic in the drinking water increases the risk. Other things are permanent hair dyes. These are from the UA guidelines. When we come to about the pathology, mainly morphologically we can classify it is into the flat lesion as well as papillary lesion. Where the flat lesion of the urothelial carcinoma in situ and the invasive urothelial carcinoma. Papillary lesions, invasive urothelial as well as papillary urothelial carcinoma and papillary urothelial neoplasm of low malignant potential and papillomas. So histological type.
Nabil, you have
take
5
it.
minutes.
Okay, yes. It's a benign. There are epithelial metaplasia and papilloma and nephrogenic adenoma and leukoplakia and cystitis cystica. Those are benign types of urothelial carcinoma which can found in a bladder as a bladder lesions. So even though leukoplakia is considered in other places as a pre-malignant lesion, here usually not considered as a pre-malignant. That's why I have to mention. And as a precursor lesions, mainly non-malignant lesion where urothelial proliferation of uncertain malignant potential, flood lesion with atypia and papillary aspects and reactive atypias. And atypia of unknown significant where pre-malignant lesion and urothelial dysplasia. Malignant is a urothelial carcinoma in situ. And invasive urothelial carcinoma, which have a urothelial carcinoma have variants where the urothelial there are other carcinomas as well as considering the bladder carcinoma. So the variants of urothelial carcinoma, where the squamous variant, glandular, as well as micropapillary and nested variants and plasmacystoid, and likewise small cell variant and sarcomoid variants and neuroendocrine variant, and some urothelial carcinoma with other rare differences. Some are unfavorable and some are favorable in a histological type. So according to this variance implication, where most of have a worse prognosis than the PO high-grade urothelial carcinomas. So presence of lymphovascular invasion in the TURBT specimen is associated with the increased risk of pathological upstaging, the worst prognosis, and 80% of the urothelial carcinomas contain some mixed differentiation, most commonly squamous cell types. And altered growth patterns and particularly micropapillary and nested variants carry a poor prognosis, even for non-muscle invasive disease. And when we consider about the carcinoma in situ, it's a non-invasive flat high-grade tumors with severe nuclear atypia and loss of cellular polarity, non-cohesive and cellular structure. Different from dysplasia due to loss of umbrella cells. And genetic abnormalities more similar to high-grade invasive urothelial carcinoma. That is, we consider mainly this is a high risk. Thus considered precursor to high-grade invasive carcinoma. Clinically, CI is associated with the invasive tumors, carries a worse prognosis. It's a 45 to 65 5-year mortality rate. Papillary urothelial neoplasm of null malignant potential, where papillary growth pattern is a minimal cytological atypia, but usually and cellular cell polarity is maintained, but nuclei are mildly enlarged. They are progression to the muscle invasive blood cancer is less than 1%. There are other conditions, the papillary urothelial neoplasm of low malignant potential and the comparison to the papilloma. That's I will skip this slide. And stage of the cancers according to the muscle invasiveness, which mainly I want to mention is about TA, which is non-invasive type papillary lesion, and the carcinoma in situ is the blood lesion. And the T1 is mainly the invasion to the lamina propria epithelial connective tissue. Others are according to the muscle invasiveness, and T2, T3, T4, according to the invasiveness and depth. According to the grading, WHO 1973 grading is divided into 3 categories, mainly well differentiated, moderate differentiated, and poorly differentiated. In the WHO, in the 2004, where it comes to the papillary urothelial carcinoma of low malignant potential and low grade and high grade. So when we consider about this categorization, most of the some of the grade 2 are classified in a high grade when compared to the 1973 WHO category. Now it part of the grade 2 into the low grade and part of the grade 2 into the high grade. That is the clinical significance and mainly the progression of the disease. And the molecular classification of bladder cancer, where molecular markers and their prognostic role have been under investigation. And these methods in particular complex approach, such as stratification of the patient based on molecular classification, are promising but are not yet suitable for routine application, because like a breast cancer, where the luminal and basal types as well as the molecular types have differentiated for their responses as well as their behavior. So this evaluation of diagnosis and the the clinical history and examination via their presentation, and after that analysis. Just I want to mention some about this cytology, where the sensitivity is the low grade things are very sensitivity is very low, and high grades their sensitivities ranges 28 to 100 in the different studies. So cytology is used not recommended until all the stages of evaluation is negative. Then later we can elderly patient we can do even cytological assessment. Molecular markers is still not considered as not a better molecular markers at the moment to evaluate the bladder's malignancy. And CT urogram is considered to in the bladder localized bladder CA, all the patient ideally initially evaluate, but in a IUA recommended where the only the specific selected cases where the trigone tumors and multiple tumors and high risk tumors. Those are the indication to do the CT urogram. And if not available, we can do even IV urogram, and the CT urogram are more beneficial with just an structures and upper tracts evaluation. And other thing, we can do the ultrasound scan is the basic initial evaluation where it can important workup for the hematuria characterized as well as renal masses and hydronephrosis and intraluminal bladder masses. And diagnosis of CIS cannot be made with imaging modality. So cystoscopy is the gold standard to evaluate for the evaluated hematuria diagnosis of bladder cancer. And in the evaluation of hematuria, where all the investigation negative, we have to do flexible URS, ureteroscopy or semi-URS to evaluate to upper tract evaluation. So the other model of the after evaluating all the things, we have to go with the for the diagnosis purpose, we have to do if there's a lesion, we have to do the resection. There's a TURB, you can do with en bloc of piecemeal resection, where we can identify the histological pattern of the tumor type as well as tumor grade and depth of invasion with the histology, as well as we usually not practically we do the identifying the CIS, the lesion abnormal areas. We have to do the random biopsies even if it's suspicious in the same time. There are the modalities which have include the the photodynamic and narrowband imaging. If available, those can be used in those instances to evaluate the abnormal areas to find out. So other things according to the predicting the disease recurrence and progression, where after the histologic evaluation of the tumors, we the number how many tumors and the diameter of the tumor and the recurrence rate how many times and the category of the tumors and concurrent CIS and the tumor grade, we will categorize these into the low risk and intermediate risk and high risk group, and according to that we will categorize and management and everything we'll discuss in another non-muscle invasive category. So this probabilities of disease progression and the progression, the lower and intermediate and high risk groups I have mentioned in the diagram, where it has a high risk group, very high progression rate in even 1 year around 60%, and 5 years around 40%, and 10 years in a 53% of the progression of the disease, even it means non-muscle invasive to muscle invasive. So we aggressively have to treat in the high grade tumor, high risk tumors and very high risk tumors, and the low risk and the low grade risk tumors we have to manage in a patient on a surveillance. So this is my presentation regarding the core topics of biliary pathology and evaluation of hematuria. Thank you.
Thank you very much, Nabil, for a nice presentation. We will move to the experts for any comments.
Nabil, it's good you covered most of the area.
Yes, sir.
Any questions from the audience? Neville, sir, you want to ask any questions, or shall we?
Yeah. Well, if you for this microscopic hematuria or non-visible hematuria, I'm just asking the speaker.
Yes,
I'm happy
yes.
to let go the first instance you get a significant microscopic hematuria. Let go as it is given in certain other. What is your view? What is the practice you will?
my perception is if the younger the patient, if a patient having a symptomatic microscopic hematuria initially like a UTI and treat and see the patient in the repeat follow-up in the clinic level, and it may more towards urolithiasis. An elderly patient who is coming with the elderly more than 40, or elderly, not elderly, but in the risk category group with any underlying risk factors has to be considered. Then we have to thoroughly evaluate to exclude until the complete workup. We have to underlying malignancy.
Yeah, detecting hematuria, microscopic hematuria in dipstick. What are the shortcomings?
Because dipsticks up to 10, I think 10 RBC, this detects around 10 RBC, the one dipstick detecting, but we microscopically only we see the 3 RBC. So there is a lag period in between the 3 to 10 where you can miss the microscopic hematuria in the dipsticks.
Yeah, when you're getting a MSU, mid-sample urine for hematuria, what is the technique you adopt? How do you collect the specimen?
Usually, mid-stick, not early morning samples, and then we collect in the, ask the patient to pass the initial part of the urine and then collect in between midstream where you can, patient can stop and take the urine sample, and the menstrual period, the females, we have to consider about the absence of the menstruality, and there is not recent instrumentation, no any catheterization. Those has to be considered before collecting the sample.
Yes. So finally, this using photodynamic diagnosis, so blue light. Do you know any studies which shows its advantages or anything?
Sorry, sir.
Photo study, yeah. There's photo study which has been started in 2017 and completed in 2022 shows no benefit. So in the long run, so it's not going to be beneficial. Okay.
Yeah, Nabil,
that's all right. Yeah.
Yes, Nabil, yes, can I give a small case scenario?
Yes, okay.
Now,
okay.
It's related to hematuria assessment. Let's suppose you have a patient, 65-year-old patient, heavy smoker, coming with recurrent.
Again,
65-year-old. Sorry, it's a 65-year-old heavy smoker.
Okay.
Coming with recurrent episodes of visible hematuria.
Okay.
And his creatinine is 2.3 milligrams per deciliter. And you have performed a flexible cystoscopy, which is perfectly normal. You can't identify a cause so up to now. How will you proceed from this point onwards? What are the alternatives available?
Yeah, initially I will go through with the history, even though history and examination with the painful hematuria and associated UTI, dysuria and symptoms. And then with that, I will assess the patient, mainly the examination wise, any palatability of the kidney and the DRE, mainly finding to identify an enlargement of the prostate.
Your examination findings are all unremarkable.
Yeah, okay. Then I will go through with the imaging model. First line, I will consider the ultrasound scan of the abdomen to visualize the mainly the upper tract as well as the any renal masses as well as any blood lesions. Even the more than 1 centimeter lesions we can see sensitivity is high because of the superficiality, and with the full bladder
okay, your ultrasound scan has shown a mild upper tract fullness in the left side.
Yes.
That is exactly the wording. No other identifiable lesion.
No, only upper tract dilatation. Then can you? There's something. The interrupting. The net is interrupting, sir. Only upper tract dilatation.
Yeah, upper tract dilatation is mild. Upper tract dilatation is noted in the left side.
Yeah.
Yes.
So then I want to consider I want to do the X-ray KUB to exclude any underlying stone, because if the ultrasound
what is the pickup rates of your X-ray KUB?
X-ray KUB mainly I want
to pick up stones.
Pick up stones. Around 70% of the radiopaque stones can be detectable in the X-ray KUB. So in sense, I can do X-ray KUV to evaluate low lying because the ultrasound
Remember,
scan is not
this sort
sensitive.
of case, now you are strongly suspecting an upper tract malignancy more than a stone here because it's heavy smoker. So how will you proceed towards that direction?
Then I will definitely consider next CT urogram, sir. CT urogram is
his
the
creatinine,
second.
His creatinine is 2.3. Your nephrologist is vehemently protesting to perform a CT urogram.
Yeah. Then I can consider the even another option is even non-contrast CT as an initial evaluation for this patient. Mainly otherwise I will consider the MR gadolinium MRI.
So do you think your patient with high creatinine, is it safe to proceed with MRI? What is the risk of MRI in this patient?
It's causing nephrogenic fibrosis. The risk is the systemic nephrogenic fibrosis, gadolinium induced. And even without contrast gadolinium, I can assess with MRI. MRI have some comparatively.
Now, as a urologist, any other alternatives that you have in your armamentarium?
Yeah, we can.
To assess the upper tract, particularly the left side.
I can do the invasive procedures because I try to do mainly the non-invasive procedures initially. So I will consider the invasive as a flexible UR. I try to do if a rigid or flexible URS for this patient. It's availability.
How will you improve your, now let's say you have planned for a ureteroscopy. How will you improve your pickup rates with the flexible ureteroscopy? Anything else that you would do merely rather than merely visualizing? Any imaging that you can combine with your ureteroscopy to find out any filling defects?
I can do retrograde RGPG. I can do the retrograde pyelogram with because any filling defects and the lesions I can identify.
That's one option. Anything else? You do your ureteroscopy and there's a red patches in the upper the ureter and the renal pelvic area. You are not sure what you are dealing with.
So I can do the biopsy. I can do the biopsy. The suspicious. I can do the biopsy in suspicious areas, the URS.
Right. Anything else that you could do?
Band. Yeah, narrow band. This means the narrow band imaging.
Any other this assessment with the cytology or any mode of assessment with the cells, tissues?
It means
you can take upper tract washouts for cytology, isn't it? With the same patient in the same sitting. Rather than merely taking a urine sample for cytology, the upper tract urothelial washouts for cytology will have a higher sensitivity.
Yes.
Comparatively. Do we have any time or can we proceed with the next one? What is the?
I think better to go for next because already exceeded the allocated time.
Right. Okay.
So next topic is management of non-muscle invasive bladder cancer and elaborate of BCG will be done by Dr. Satyamurthy Prasanna.
To my slides?
Yes, we can.
And see you. Now we can.
I am Dr. Prasanna. Good evening, all of you, my teachers and colleagues. The management of the non-muscle invasive bladder cancer. When you consider the management for bladder cancer, we can categorize into whether it is localized or locally advanced or metastatic. Localized means it's a non-muscle invasive. So it is only within the epithelium and subepithelial connective tissue. And when we consider the locally advanced means which here's the muscle layer, that means T2 or T3 diseases. And when we consider the metastatic, it's to the non-regional lymph nodes or other organs. So for the non-muscle invasive bladder cancer, main mode of treatment is the TURBT followed by the intravesical treatment, whether intravesical chemotherapy or immunotherapy. That's the main mode of treatment. But some situation we can go ahead with a radical cystectomy. And when we consider the muscle invasive, main mode of treatment is the radical cystectomy. But if patient is not fit enough for the radical cystectomy or refusing, then we can consider the trimodal therapy. They will discuss in the later part. And in the metastatic cancer, obviously it's a palliative treatment. So patient with the symptoms, we can palliate the symptoms and mainly depend on the chemo. So when we consider, once we diagnose the bladder cancer, and when we stage the disease, our main mode of initial treatment is the transurethral resection of bladder tumor. So usually we will do the white light with the white light cystoscope. We do the resection. This resection can be do as a piecemeal resection or en bloc resection. But this en bloc resection usually gives a better sample, and we can remove the tumor as a whole package, and same time we can resect the surrounding area and the muscle separately. But when we consider for the larger tumor, then it can be a we can perform the en bloc, then we have to go ahead with the piecemeal resection. In piecemeal resection, we have to assure, or we have to confirm we are resecting the muscle layer as well as the normal surrounding epithelium as well. Then our resection quality, usually we need the muscle layer in our biopsy. But when we consider the low-grade tumor, that means L1 low-grade tumor, then without muscle layer also we can, our resection quality we can compare. But when we consider the grade 2 or grade 3 tumor, the muscle layer should be there in the biopsy. And there are other mode of for the diagnosis as well as for the resection. There are other photodynamic diagnoses. Here mainly they use the blue light cystoscope or fluorescence cystoscope. In fluorescence, they can instill some agent like 5-amino-leucinic acids or hex-amino-leucinic acids. Then they can do the resection. But as Neville sir discussed, initial our trial shows the recurrence rate and those progression-free survival both are increased with these newer methods. But now the conclusion is that's inconclusive for this photodynamic diagnosis. Then our second part is the second TURBT. So always is it necessary to go ahead with the second TURBT or in a selected patient? And when we select, when we have to go ahead with the second TURBT. So usually with the low-grade tumor, and we resect the muscle in our resection, then no need the second TURBT. But if it is high grade, or if our resected specimen doesn't consist of muscle, then we have to go ahead with the second TURBT. So second TURBT is not necessary all the time. Then if we plan for...
Prasanna, your slides are not moving. I don't know whether you...
Yes, sir. And our this second TURBT, if we consider a second TURBT, then we have to consider between the 2 to 6 weeks time. Once we do the TURBT, then our main aim, the next management part is the intravesical chemotherapy. So usually we have to instill the bladder with the mitomycin C, but other than the mitomycin C, there are epirubicin or pirarubicin or even gemcitabine. With the newer studies, so this gemcitabine is giving the superior recurrence rate and disease-free survival. That means recurrence and progressions are superior with the gemcitabine. And this intravesical chemotherapy installation, it will reduce the recurrence rate by around 14%. So to improve the intravesical installation of this chemotherapy, there are some methods. We can adjust the pH. So to adjust the pH of the urine, we can give oral drugs to adjust the pH. And duration of installation, whether we can give a 1 hour of installation or 30 minutes. So when we consider longer duration around 1 hour, then the efficacy is high. But problem is the side effect, other part. And drug concentration, what is the usual? We are 20 to 60 milligram prime for mitomycin C. So drug concentration, these are the main part. And to increase this intravesical the chemotherapy penetration, we can use the hypothermia. We can induce some hypothermia with different methods. It can be a microwave induced or electromotive drug administration. We can use some thermal energy in the intravesically, and we can do the intravesical treatment. Then other part of the management is the intravesical BCG immunotherapy. So that's a chemotherapy. This mitomycin, epirubicin, gemcitabine, also chemotherapy drugs. They mainly act on the DNA synthesis and act as a chemotherapy drug. This BCG is immunotherapy. It's usually activate the type 4 immunohypersensitivity reaction and act against the tumor cells. So it will reduce the recurrence rate and progression rate. So compared to the chemotherapy, BCG is the better one. It will reduce the recurrence rate and progression. Then we can think all the patients we can give BCG immunotherapy, but there are side effects. So mainly they can cause the local side effect and systemic side effect. Local side effect mainly cystitis, hematuria, symptomatic granulomatous cystitis or prostatitis, and the epidermolysis. These are local, and even systemically we can they can cause arthralgia, arthritis, that is usually reactive arthritis, and persistent high grade fever, BCG sepsis, and allergic reaction. So due to this side effect, we have select the patients for the BCG immunotherapy. Then the optimal BCG schedule, the usual BCG schedule is the standard one is induction. We have to give the induction dose around 6 dosage. Then maintenance, usually we have to give 3 weekly at the 3, 6, 12 months interval. So minimum maintenance we have to give 1 year. And maximum we can go ahead with the 1 to 3 years. That's depend on the patient's factors. Then other mode of treatment is the radical cystectomy. So why we are going for the radical cystectomy? Because there are staging accuracy for T1 tumors by TURBT is around 0.5%, around 50%. So even with the TURBT, there are some stage migration is there. And some non-muscle invasive bladder cancer progress to muscle invasive in the follow-up period. There are some percentage of non-muscle invasive cancers, they progress to muscle invasive. And patient who progress to muscle invasive bladder cancer, the prognosis wise very bad compared to the primary muscle invasive bladder cancers. Those who are from non-muscle to muscle invasive, the prognosis is bad. So there's a treatment for the radical cystectomy also there. So there are main 4 treatment options are there. One is the TURBT, other one is the intravesical chemotherapy, intravesical immunotherapy, and 4th one is the radical cystectomy. Then we have to select with those management option. For that already Dr. Nabil has discussed. With our primary TURBT, we have to categorize the patient into 4 groups: low risk, intermediate risk, high risk, and very high risk. Depending on those, there are 7 parameters: number of tumors, and size of the tumor, and tumor grade, and there's a concomitant carcinoma in situ is there or not, and this is primary or recurrence, and the age of the patient. Depending on those factors, we can categorize the patient into these 4 categories. And with these 4 categories, there are some risk calculators are there. There are different groups are there. There's a EORTC groups that's mainly European Organization for the Research and Treatment for Cancer, and there is a few different groups are there. With those groups, we can categorize we can estimate the progression of the cancer. That means recurrence of cancer. So when we compare this WHO 1973 category, if it is low risk category people, there's a 3% risk to progress in 10 years. But if it is very high risk people, there's a around 59% risk to progress in 10 years. That means there's a chance to muscle invasive is around 59%. So we can calculate the risk of progression and risk of recurrence. So our primary treatment with the individual risk category group, when we consider the primary treatment, the low risk disease people, that means the risk of progression is around 3%. Main treatment mode is TURBT followed by single post-operative installation of chemotherapy. So we have to do the TURBT followed by within 24 hours, preferably within 2 hours. So usually we have to do in the theater or in the recovery area, we have to give the post-operative, we have to give either mitomycin or other drugs. We have to, that's enough for the low risk category people. When we consider this intermediate risk people, there's a chance of around 8 to 8.5 chance, there's a chance of recurrence. So we have to consider TURBT plus 1 year full dose of BCG. So after TURBT, we can assess the patient with the histology. So in the after assessing histology, in the after 2 weeks, after settling the TURBT and hematuria part, after post-surgical settling, then we can start the BCG treatment. So there are induction regimes, there are induction treatment, and 3-week installation of 3, 6, and 12 months. So 1 year full dose of BCG is enough for the intermediate risk group people. Then when we consider high risk disease people, there's a around 14% chance of progression. So we have to consider the TURBT plus full dose BCG vaccine for the 1 to 3 years. This 1 to 3 years we can change. We can change depend on the patient and patient factor. We can consider the patient factors and we can change these 1 to 3 years. There are for the patients related factors we can consider with the other scoring system. Then we can change according to the what's the ideal duration for this patient. So again, same the induction dose and the 3-week, we can give the maintenance dose of BCG. Or we can directly consider for the radical cystectomy. So those who are not happy to avoid with the BCG or patient refuse for the BCG, then we can think about the radical cystectomy for the high risk people. But oncologist point of view, they are think the safest one. Oncologically, the radical cystectomy is the safest method of treatment for the high risk people. Then other one is the very high risk population. Here the around 50 to 58% risk to progression. So main mode of treatment is the immediate radical cystectomy. And we can consider the diversion. But if the patient is not fit enough for the surgery or not candidate for the cystectomy, then we can think about full dose of BCG vaccine, BCG intravesical BCG. So this is according to our risk categorization. This is the main mode of treatment for the non-muscle invasive. There's a nice diagram in the this AU guideline. So after following TURBT, I don't know whether you can see the diagram. After following the initial TURBT, we can start the initial chemotherapy, intravesical chemotherapy within 2 hours. Then we can categorize the patient into low risk, intermediate risk, high risk, and very high risk population. But if during TURBT, if there's any bleeding or perforation, then we can't give this intravesical chemotherapy. Then we can categorize the patient into these 4 groups, and according to the 4 groups, we can do our management. Then our follow-up or surveillance also, according to this the risk categorization, our follow-up also, we will change our follow-up.
Prasanna, you have 5 more minutes.
Yes, sir. Then this is our standard recommended management according to the available level 1 evidence. That's the our standard management, but there are other management. One is the whether we can go ahead with the neoadjuvant before the TURBT, we can go ahead with the neoadjuvant. And other option is the chemoresection. Chemoresection means without doing any surgery for the low grade tumors, and we can go ahead with the pure only intravesical chemotherapy rather than doing the TURBT. So there are trials for the neoadjuvant. There are trials, but one trial says there's no difference. Giving neoadjuvant or without neoadjuvant TURBT, there's no difference. But there's a Korean phase 2 trial is there that shows 63% reduction in the risk of recurrence, but that is also not completed trial. And there's a for the chemoresection also, there's a mainly two studies are there, but there's no any evidence of promising evidence for this supporting for the chemoresection. Then other category of people are BCG unresponsive, high risk, non-muscle invasive bladder cancer. So if there's any BCG unresponsive, the definition for BCG unresponsive is those with a persistent or recurrent carcinoma in situ or high-grade Ta/T1 tumors after adequate BCG. So here the adequate BCG means at least we have to give the 5 doses of induction for the total 6 doses. At least we have to give 5 out of 6 doses of induction and 2 doses of minimum 2 doses of maintenance dose. That's mean adequate BCG. So with those adequate BCG, if the patient is persistent or recurrent cyst or high grade tumors, then we can categorize into BCG unresponsive. Or patient with the initial clearance of non-muscle invasive bladder cancer, but with adequate BCG therapy, but again they can develop the recurrence. If it is high grade for 6 months, but if it is cyst for minimum 12 months, then we can define as a BCG unresponsive high grade tumors. So depending on that, we can categorize the patient whether it is BCG refractory to BCG or BCG there's a relapsing tumor, or there's a patient BCG unresponsive, and other one is the BCG intolerance. BCG, those 4 categories tumor. Then our treatment. What are our treatment modalities? So for these 4 categories, our main treatment modalities is the radical cystectomy. So if the patient is the only promising treatment is the radical cystectomy for these BCG unresponsive patients. But there's a study for this pembrolizumab. That's a PD-1 inhibitor. There's a PD-1 program death inhibitor pathway. That pathway, the main our thought is this BCG unresponsiveness is mainly through this program death 1 pathway through that. So we have to start this pembrolizumab, and there's a trial is this Keynote 57 trial, and it's somewhat they are saying compared to the radical cystectomy, if patient is not fit enough for the radical cystectomy or refusing, then we can think for the pembrolizumab for the BCG unresponsive patients. Then when we consider the follow-up, so main aim is to identify the risk and recurrence and progression. So here we need the proper surveillance for the following the primary treatment. So our follow-up mainly depend on the white light cystoscopy. So even there are newer molecular markers are there. Still the recommended one is the white light cystoscopy is the recommended for the follow-up. But if it is high grade tumor, then the sensitivity for these tumor markers are around 91%. So we can combine. Recommended one is the white light cystoscopy. So first cystoscopy after TURBT at 3 months. It's the important prognostic indicator. After that, we can categorize the patient depend on our low, intermediate, high, and very risk categories. Then we can think about the interval of cystoscopy and the adjuvant other investigation, whether we can go ahead with the upper tract imaging modalities. Those things we can consider depend on our risk category.
Thank you, Prasanna. You stick the time and a nice presentation. We'll move for the experts for any comments.
Hello, Prasanna.
Yes, sir.
Yeah. Now you suppose you got a 70-year-old COPD patient. He had an ultrasound scan that says some suspicious bladder tumors there. Unfortunately, you don't have a cystoscope, right? So now you plan to do a TURBT, right? So what
Yes.
sort of anesthesia you prefer for this?
For the TURBT, sir, preferred anesthesia is the general anesthesia because there's a high chance of patient getting the obturator nerve spasm and bladder perforation during the resection. But this patient with the
specify the general anesthesia a bit more.
sorry, sir.
You specify the general anesthesia a bit more. General anesthesia with
the muscle relaxation, sir.
Okay. Now this patient's anesthetist says, no, I can't give relaxation because he's having severe COPD. If I intubate, I won't able to recover him. So what is the next option in that case?
Yeah. Next option, sir, we can do the under spinal anesthesia and we can see the area. We can see if it is mainly in the not in the lateral wall, mainly in the dome of the bladder or mainly anterior posterior wall, then we can do. Or otherwise, we can do the if patient is not fit enough for any major thing, then we can resect, and if it is really muscle invasive one, then we can abandon the procedure.
Yeah, suppose it is in the lateral wall. Now the anesthetist says I can go spinal. Now tumor is ultrasound scan. It is in the lateral wall. Now what you can do?
Still, sir, I can do the resection with the superficial muscle layer. If it is superficial muscle layer is involved, that
anything to prevent obturator contractions. Anything anesthetist can do with the spinal. Any combined procedure? Any blocks?
Yes, sir. They can give a nerve block, but I am not aware, sir.
Obturator block, right? Okay. Now this patient is in the theater. Now you are because unfortunately you have not done a cystoscopy before, but you are going to do a TURBT. So what are the specific things you have to include in the op note regarding your procedure?
Yes, we have to do mainly the tumor location, sir, and the bilateral urethral orifice is involved or not, and the prosthetic urethra is involved or not, or is there any abnormality in the prosthetic urethra? And the muscle layer, we have resected the muscle layer.
Yeah, anything regarding the tumor site? Appearance?
Yes, tumor site is whether it is mainly the typical papillary type or any concurrent carcinoma in situ is available or not.
How it look like carcinoma in situ if there is any?
Yeah, usually it's flat lesions, or flat and reddish lesion, and like abnormal mucosa, sir. But it's difficult to differentiate with the inflammatory areas.
So once you resect the tumor, you said that you resect the tumor and you said about the muscle and things. Anything else you have to specifically mention in the op note? Because the second time, if you are not there, somebody else see the histology report, or it's a T1 tumor and no muscle invasion. So it might
complete resection.
Yeah, completeness of the resection, right? Whether you have seen any tissues, macroscopic tumor tissues in the base as well as surrounding macroscopic tissues. Whether you have done a complete resection, right? Okay.
Yes,
and what else? You said about the tumor close to the VU and trigone. What else? Location of the tumor. What else?
And prosthetic urethra is involved or not?
Yeah. Okay. Now you're suspecting having a prosthetic urethral involvement or any tumor close to the trigone. So what you are going to do now?
Then those patients are we have to do the upper tract imaging. That's we have to.
I'm telling about. Yeah, what I'm telling about, there's tumor close to trigone and there's suspicious area in the prostate. I mean, you have a doubt now the prostate urethra involved or not. What you can do now?
we can take the biopsy from the prosthetic ureter.
Where do you take and how you take?
Ah.
Lesion, yes, you can take the lesion out. But if there's no lesion,
Then we have to take the proximal to the ducts.
so
And
5 to 7 o'clock position, you can with the diathermy loop, you can resect.
5 to 7, yes.
Right. Okay. Okay. Then you had to mention about the completeness of the resection, depth of the resection, right? What
Yes.
sort of resection you did as Nabil said, standard 10 block with the right?
Yeah.
And right. Okay. Now this patient, what are the criteria to decide whether this patient, because you are doing the TURBT, and then post-operatively you decide whether to give a mitomycin or not within 24 hours. So what are the criteria you decide whether to give mitomycin or not?
I will see, sir, there's any contraindication for mitomycin, mainly the contraindication mainly during any perforation or any evidence of muscle invasiveness. Then if nothing, then we can, actually muscle invasiveness is not a contraindication, but if there's evidence of muscle invasiveness or perforation, then I won't give mitomycin C. Those other patients, always I will give the mitomycin C.
Suppose this patient is a TURBT in January and he comes after 3 months with a repeat recurrence. Are you giving mitomycin? Give mitomycin if it is a recurrence within 1 year, right?
Yes.
Okay. So usually we give mitomycin if it is looks like a TA or T1 disease rather than muscle invasive, right? Okay. Okay. So what else you do? You do the resection, and then what are the other, but anything else you need to do? You need to take some random biopsies around the tumor to see carcinoma in situ. Okay. Anything else, Ranga?
Yeah, there's a greater enthusiasm about this alternatives to intravesical BCG. Why do you think, Prasanna? This is a hot topic in the field now.
For the alternatives,
no, there are a lot of new papers coming up looking for alternatives for BCG. Why do you think there's a greater enthusiasm? What are the reasons behind this? What do you think?
Yeah, one is the, sir, BCG is with the side effect, other one is the BCG shortage.
Yeah, quite correct. The main one is BCG shortage. It's a worldwide, there's a shortage. And then the other things are the tolerance issue and the BCG failure. Yeah. These are the main things. And in your presentation, you mentioned certain alternatives for BCG or alternatives to BCG. Can you tell me in brief, 1, 2, 3, 4, what are the alternatives available? Say you have no access to BCG for a non-muscle invasive bladder cancer who's fulfilling the criteria for BCG. What will you do? What are the other options available for us?
Yeah, then we can give the intravesical chemotherapy for 1 year duration, sir. We can increase the duration for intravesical chemotherapy one.
Yeah, correct. That is intravesical chemotherapy maintenance, right? We usually give only 6 cycles, but here you can give a maintenance up to 1 year. So what are the agents that you could use? Apart from mitomycin?
Yeah, epirubicin and the gemcitabine.
Right. So as you said, the gemcitabine is superior than the others, right?
Yes.
Okay. And then what are the other options available?
Other options are, we can think about the radical cystectomy, but that is for the very high and high risk patients.
Yes, high risk and very high risk patients or CIS, then you can think about early radical cystectomy, right? What are the other options? Just name them.
No, sir, I am not aware.
And the other one is, as you mentioned, the delivery systems. There are improved delivery systems for the chemotherapy. The hypothermia and then so many other delivery system variations, modalities have come up. And the research level, they are looking for combined therapy rather than monotherapy, sequential therapy. Mitomycin and gemcitabine sequential therapy. And then using other bacteria and viral agents incorporated into the treatment options. There are something newly coming up. I think it's best to read around these topics a little bit.
Can I ask a couple of questions? If time permits. The BCG, suppose BCG is available, how many people will continue BCG therapy in full course? And how many BCG doses are given in a full course with the maintenance? Any idea? 27 doses. Okay. So this all 27 doses are continued by how many people roughly do you think that all the studies have shown? You were mentioning about toxicity, be little specific about toxicity. Only less than about 30%. People will continue the whole course. So how can you reduce the BCG toxicity? Are there any methods used to reduce BCG toxicity?
Yeah. Yes, sir. One thing, we can reduce the dose, sir. We can reduce the, sir, maximum 1/3 we can reduce. If it is, if you reduce the dose around 1/3, then the
Are there any studies to prove that the reduced dose, that is instead of 81 milligrams, you give 27 milligrams? Is there any difference in the long run, and are there any studies? There are studies to show that there is no difference. Okay, but you better know about the study because it's a meta-analysis actually. Okay, right. So any study about hypothermia and any idea about hypothermia and chemotherapy? The HIVEC study, has just the report has come out. The final meta-analysis. Is there any difference in HIVEC? HIVEC is hypothermia and intravesical chemo versus just intravesical chemotherapy. No difference. Okay, that's the final conclusion. So they are looking for the other methods like microwave and various other things. But the hypothermia itself is not going to work anymore. Okay, that's it from me.
Thank you, Nabil sir. It's always happy to have you on board. You always help with UroMET, sir.
This study written today. I thought I'll join.
Regarding the frequency, is that the Nimbus study said that production of dosage of BCG?
Yes, that's right. And that actually shows there is not much of a difference, and they can continue with lesser side effects, isn't it?
Yes, sir.
Yes.
So that is instead of 81, you give 27 milligrams, 1/3, as he mentioned.
Prasanna, one more question from me. If you happen to do a TURBT, you see a tumor at the ureteric orifice. What are the precautions you will do rather than routine, standard TURBT? Any precautions you do if you see a tumor at the UO?
We can do the before resection. We can do the ureteroscopic evaluation. There's any and to exclude the upper tract continuation, and then we can do the stenting. But they says the resection at the UO, there's no need for the stenting. Postoperative stenting is not always necessary for the study says, but usually if it is tumor associated with the UO and if we plan for the resection, our usual practice is we are going to do the stenting and resection.
Stenting, I'm going to ask the expert panel also because it can increase the upper tract cancers if we stent UO tumors. 3 to 4-fold rise, is that correct? Because UO tumors, what they tell is minimal cauterization.
There's some controversial evidence because what they say is if you place a stent, you are inducing a reflux system in the particular site. So whatever the microscopic tumors in the bladder, then there always a chance of reflux and they can end up with upper tract tumors. But this is a very minor percentage, and of course there's a it's highly variable between studies. But as you said, that is one explanation that they give.
Yeah, you're right there. If I just add a little practical point, 15 seconds. Somebody, I think Manjula, asked you how to measure the size of a tumor. Now, suppose you are doing a study and you have to report the size of the tumor. How would you do that? Now, when you take it out in piecemeal, you can't measure the size, no? So how do you think you can measure the size?
Yeah, with the biopsy forceps, our resectoscope biopsy, the size.
Resectoscope and biopsy forceps are two things, no? So which one we will use to measure the size? The loop length. The loop diameter is 1 centimeter, right? So I think you have to keep the loop close to the tumor before you cut, and then you have to measure the size and report it. Otherwise, you won't be able to do.
It's a famous question from late Dr. Sirosha Gunadhan, sir.
Yes, that's right. Yes. In fact, in one of our studies, the editors have asked, "How did you measure it?" So So I think this is the answer. The same thing, applies for how to measure the size of stones after doing laser tripsy. To see whether those are small enough to come out.
Yeah.
Same thing. Compare it with the size of the laser fiber. Okay.
Yeah.
Sorry. Yeah.
Prasanna, added to Taha's question, when you do any resection, any tumor very close to VU, and better to leave a guide wire at the time of resection. Sometimes you may fulgurate or damage the VU during your resection. So you know where the VU, if you leave a guide wire, if you do a tumor very close to the VU.
Prasanna, if you have consented the patient for TURP, and when you go in, you see a bladder tumor, what would be a decision?
Yes, sir. We can combine the TURP and TURBT. There's no any the patient's disease-wise. There's no any difference. So we can combine. But I am not aware, sir. But
yeah, if it is small capillary and not multifocal, we can combine surgery. Neville, sir, is that sir?
Yeah, I think the studies have shown that low-grade tumors and you can combine it. But then if you have not assessed the prostate and if you have assessed the prostate, I think you will give chance to the bladder tumor resection, and I would go at a later date, because you don't know what is it's a tumor. It all depends on the tumor. If it is sort of high grade and sessile tumor, resecting that with the prostate will be a bit of a problem, unless it is sitting on the prostate gland itself. I would keep the prostatectomy for a later date, because you never know if it's a muscle invasive one, you will end up in a cystoprostatectomy. So what's the point of resecting the prostate then, So because of that, it all depends on the appearance of it. Suppose it's a pun lump or that's a superficial tumor, might be able to resect that and then continue with prostate. And remember that if you cut the prostate, you might not be able to put the chemotherapy at all, that 24-hour chemotherapy is out. So because of that, I would rather do the tumor first and come back to the prostate later on.
Thank you.
Okay, thank you, sir. I think we can move on to the third topic.
So one last question, Prasanna. Now we have mentioned about the.
Okay, so third one is the management of muscle invasive bladder cancer, but the presenter is not in the audience. I think whether to go for the fourth one, or we can ask some questions regarding the muscle invasive bladder cancer from the presenters to cover that thing. Otherwise, we might not find a date. There's things like investigation once the patient coming by histology diagnosis muscle invasive disease, how to stage and how do you perform the salient steps of radical cystectomy and the crucial point of lymph node dissection, and then urinary diversion techniques and complications. What do you think, sir? Whether to ask or move to the other?
Yeah, the third present is not there, is it?
Yes, sir. Yeah, she is in, I think, other country, going to the Osteg, and it was delayed.
Oh, okay. So I think organizers, what do you think? I think there's one more presenter available, is it?
Yeah, the metastatic bladder cancer and upper tract TCC. So we'll move to that.
Shall you do that first and then?
Yeah.
Okay, then.
Shall we finish the presentation and then back to the.
Yeah, the next presentation is metastatic bladder cancer and upper tract TCC will be presented by Dr. Balakrishnan Pragalathan. Dr. Pragalathan, over to you.
Sir, and my colleagues, and today I'm going to talk on the metastatic bladder cancer and upper tract urothelial cancers. So the metastatic bladder cancer, about the 10 to 15% of the patient with the bladder cancer present with the metastasis at the time of the diagnosis, and more than half of the patient who present with the muscle invasive bladder cancer eventually progress to the metastatic disease. The common sites for the metastasis are mainly the lymph node is around 70%, then bone, lung, the liver, and the peritoneum. So the main prognostic factors are the performance score of the patient as well as the presence or absence of the visceral metastasis. When the 5-year survival in the lymph node only disease about the 20% and compared to less than 7% in patient with the visceral metastasis. The main treatment of the metastatic urothelial cancer had remained largely unchanged, and the standard of care for the first-line treatment with the cisplatin-based combination demonstrating an overall survival benefit. So in general, for the management purpose, we can divide the patient with the metastatic urothelial cancer into 3 categories. The patient who are fit for a cisplatin-based chemotherapy, patient who fit for a carboplatin-based chemotherapy but unfit for a cisplatin, and the patient who are not fit for a platinum-based chemotherapy. It mainly depends on the patient performance score and the glomerular filtration rate, as well as then auditory hearing loss grade, as heart failure grade, and the peripheral neuropathy grade. So the definition of the platinum eligibility, so this is a patient who are fit for a cisplatin eligible, the ECOG performance score 0 or 1, and the GFR usually more than 45 to 50, 60 milliliter per minute, and the audiometric hearing loss grade less than 2, and the peripheral neuropathy grade less than 2, and the cardiac insufficiency, New York Heart Association class less than 3. The patient who are not eligible for the platinum categories are the GFR less than 30 or the ECOG performance score more than 2, or the patient with ECOG performance score 2 and the GFR less than 60. In between, the patient can consider the carboplatin eligible. The main mode of treatment for the patient fit for a cisplatin is a cisplatin containing combination therapy with the gemcitabine. It's demonstrating that overall survival of 12 to 14 months of increment. So, and there are 2 regimes may describe that. One is MVAC, the methotrexate vinblastine and the atramycin plus cisplatin. Another one is the gemcitabine plus and the cisplatin. Because of the lower toxicity, the gemcitabine and the cisplatin now considered as a standard regime. Then the patient who are not fit for a cisplatin, but the patient who are fit for a carboplatin, around 50% of the patients are with the metastatic disease who are not fit for a cisplatin containing chemotherapy. But most of them are candidates for the carboplatin. There are 2 regimes. So one is the methotrexate carboplatin and the vinblastine. Another one is the gemcitabine and carboplatin. So in the who are the patient who are fit for a platinum-based chemotherapy, no other recommended treatment, first-line treatment recommended. Followed by this platinum-based chemotherapy, the may do the continue the maintenance therapy with the PD-L1 inhibitor. So the patient who achieving the stable disease or better after the first line platinum-based chemotherapy use a maintenance treatment with the PD-L1 inhibitors usually available. Then the patient who are progressing during or after the platinum-based treatment, that offer the checkpoint inhibitors with the pembrolizumab. Here the patient, the treatment of patient who are unfit for the platinum-based chemotherapy. So this outcome of this patient in this group has been poor. The best supportive care has often been chosen instead of systemic therapy. There are pembrolizumab and the atezolizumab as a first-line treatment for the patient not fit to receive any platinum-based chemotherapy, regardless of PD-L1 receptor status. Then the second-line systemic therapy for the metastatic disease, the checkpoint inhibitors are the PD-1 inhibitors, pembrolizumab, and the PD-L1 inhibitors. So atezolizumab. Then there are novel agents, and there are 2 groups: and antibody drug conjugate and the fibroblast growth factor receptor inhibition. There are drugs, the antibody drug conjugates, that enfortumab vedotin and the sagittizumab, and the FGFR inhibition usually the etafitin. This is the flow chart of the patient with the metastatic bladder urothelial cancer. We have already discussed the patient who are eligible for the platinum based, who are fit for a cisplatin, continue the 4 to 6 cycles of cisplatin with the gemcitabine and assess the response. If the patient who are stable or better outcome, that continue the maintenance with the avelumab. The patient who are with the fit for a carboplatin, they give the 4 to 6 cycles of carboplatin with the gemcitabine and assess the response, and if the patient the good response, continue the switch the maintenance with the available. So patients who are not fit for a platinum-based treatment, that treatment irrespective of the PD-L1 status is immunotherapy with the atezolizumab or pembrolizumab. Then the palliation to the patient with the non-metastatic, the metastatic bladder cancer, to mainly to control the bleeding. There are multiple options. The installation of the formalin, which is causing the very painful. So it should be given under general anesthesia. There are some side effects, so causing the bladder fibrosis and the reduced capacity. So they make sure the patient there is no BGJ reflex before installation of this formalin. It may cause the renal parenchymal damage. There are other options are the TURBT, or the patient who are fit for a surgery can consider the palliative cystectomy, and there are small role with the radiation and the embolization. And the surgery to unblock the ureter, mainly that antegrade or retrograde stenting and the percutaneous nephrostomy tubes. My next topic is upper tract urothelial cancer. So the upper tract urothelial cancer is uncommon and account for only the 5 to 10% of the urothelial cancer. The bladder urothelial cancer accounts for about 90% of the cancer. And now the rate has been rise in the past few decades because of this improved detection and as well as the improved bladder cancer survival. There is a pilocalcial tumor twice as common as the ureteral tumors, and the multifocal tumors are found in approximately about 10 to 20% of the cases. And the presence of concomitant carcinoma in situ of upper tract is between about 10 to 30%, and the 17% of the cases having concurrent bladder carcinoma is present. The following treatment, the recurrence in the bladder occurs is about 20 to 47% of the upper tract urothelial cancer patient, and 2 to 5% in the contralateral upper tract. The following the radical cystectomy for the muscle invasive bladder cancer, 3 to 5% of the patients develop the metachronous upper tract urothelial cancer. Approximately 9% of the patients present with the metastasis. The peak incidence in individual age is about 70 to 90 years, and it's twice as common in the men. The known risk factors for the upper tract urothelial cancers, tobacco exposure is a very known risk factors, and the presence of arsenic in the drinking water and the aristochloic acid is a chemical carcinogen which can cause irritation of the upper tract, causing lead to the urothelial carcinoma, and also the alcohol consumption. There are history of bladder cancer is associated with the high risk of developing upper urothelial cancer. There is a known factor who are recurring the ureteral stenting at the time of the TURBT, as we earlier discussed. And the hereditary, there is a hereditary upper tract urothelial cancer also. They are usually associated with the Lynch syndrome. So the diagnosis, we need to suspect the patient who are present with less than 60 years of age, or the personal history of Lynch spectrum cancer, such as the colorectal, upper GI cancer, and the endometrial and the ovarian skin cancer, or the first degree relative with the less than 50 years with the Lynch spectrum, or any age with the 2 first degree relative with the Lynch spectrum cancer. The staging depends on the TNM staging. The TA is a non-invasive papillary carcinoma, and the TA is carcinoma in situ. The T1 tumor invades the subepithelial connective tissue, and the T2 tumor invades the muscularis, and the T3 for the renal pelvic tumors, it invades beyond the muscularis into the peripelvic fat or the renal parenchyma. For the ureter, it's invaded into the periureteric fat. The T4 is a tumor invade the adjacent organ or through the kidney into the perinephric fat. For the regional lymph node, is N1 is considered the metastasis to the single lymph node 2 centimeter or less, and the N2 is considered more than 2 centimeter nodes or the multiple nodes. The diagnosis, the main presentation of this upper tract urothelial cancer is visible or non-visible hematuria. Then other one is a flank pain. It can be due to the blood colic or the tumor obstruction causing the hydronephrosis and the loin pain. And the systemic symptoms, the patient who are presented with the systemic symptoms such as loss of weight and the loss of appetite, with the malaise and fatigue, having a worse prognosis. We should investigate for the metastasis. The cytology is less sensitive compared to the bladder tumors, and the abnormal cytology may indicate a high-grade upper tract urothelial cancer when the bladder cystoscopy is normal. to improve, it's a no sensitivity is about the 70 to 84%. To improve the cytology, we can do the URS and washout and get the for the cytology. The imaging, so the CT urogram is the main mode of diagnostic investigation. It's having a high accuracy, the sensitivity about more than 92% and the specificity about the 95%. Then the patient who are not who are contraindicated for the CT, we can consider that MRI urography, but it's having a less sensitivity. It's about 75%. So always for patient with the upper tract urothelial cancer, we should do the cystoscopy to mainly rule out the concomitant bladder cancer, and then the diagnostic ureteroscopy, we can diagnostic ureteroscopy, we can say assess the appearance and the multifocality and the size of the tumor, as well as we can do the biopsy. But the study says that when we are doing a biopsy, it having an increased risk of intravesical recurrence. And for the metastatic staging, so the most around 10% of the patients are who are present with the distant metastasis, and then we should do the contrast in the chest, chest and the abdomen pelvis. The prognosis of this upper tract urothelial cancer depends on the multiple varying factors. So the patient-related factors are the old age at the time of the radical nephrourectomy associated with the decreased cancer-specific survival, and the being a smoker, having a high bladder recurrence and the disease recurrence and the surgical delay. So once the decision is made for the radical nephrourectomy, the surgery should be carried out within the 12 weeks, and the patient performance score. The tumor-related factors are the tumor stage and the grade. For the 5-year survival was 86% for the non-muscle invasive tumor, and the 70% for the muscle invasive organ confined tumor, and the 44% for the locally advanced tumor. So the other prognostic factors are the multifocal tumors and the size, tumor size more than 2 centimeter, and the hydrogelutonephrosis having a bad prognosis. And the pathological subtypes such as the microfibrilary and the sarcomatoid features also having a bad prognosis. A patient with the lymph node involvement, so the patient very preoperatively very difficult to do the detect the clinically positive nodes, and if we detected the at least to go with the neoadjuvant chemotherapy followed by the surgery. And the histology, if it is associated with more than 10% of tumor necrosis having a bad prognosis, and the cell growth pattern and the concomitant carcinoma in situ also having a bad prognosis. So the risk stratification for the clinical decision making in the upper tract urothelial cancer. So the high risk upper tract urothelial cancer considered as a multifocal disease, and the tumor size more than or equal to 2 centimeter in size, and the high grade cytology, high grade URS biopsy, and the local invasion on the CT. The patient with hydronephrosis and previous radical cystectomy for the high grade bladder cancer, and the histological subtypes. The bladder recurrence after the radical nephrourectomy. So the rate of bladder recurrence after the radical nephrourectomy is about the 22 to 47%, and the factors affecting the bladder recurrence, the patient factors such as the male and previous bladder cancer, smoking, and the preoperative chronic kidney disease. The tumor-specific factors, the positive preoperative urinary cytology, the tumor grade, and the ureteral location, and the multifocality, tumor diameter, and the invasive T stage, and the necrosis. The treatment-specific factors, use of diagnostic URS, laparoscopic approach, and the extravesical bladder cuff removal, and the positive surgical mark. The single dose of intravesical chemotherapy after the diagnostic or therapeutic ureteroscopy of non-metastatic upper tract urothelial cancer has been suggested to lower the rate of intravesical recurrence. So the management of the upper tract urothelial cancer, we can divide it into the localized low-risk cancer, and the localized high-risk cancer, and the metastatic cancer. For the localized low-risk cancer, kidney-sparing surgery is the main mode of preferred approach, and it having a similar survival rate compared to the radical nephrourectomy. There are multiple options. One is the endoscopic ablation with the flexible ureteroscope for the mainly for the management of pelvic cholesterol tumor and the ureteric tumors, and the percutaneous management is for the renal pelvis tumors, and the segmental ureteral resection, we can for the segmental ureteral resection for the proximal two-thirds ureter is associated with the higher failure rates than the for the distal ureter. The adjuvant instillation, the recent evidence suggests that the early single adjuvant intracavitary upper tract instillation of the mitomycin C in patients with low-grade upper tract urothelial cancer might reduce the risk of local recurrence. The main
5
side
minutes more.
the main side effects of this mitomycin C are the ureteric stenosis and the ureteric infection and the hemorrhage. The localized high-risk patient with the main mode of treatment is the radical nephroureterectomy. So the radical nephroureterectomy with the bladder cuff excision is a standard treatment, and or it can be open or laparoscopic robotic approaches. But the evidence says that similar oncological outcome for the organ-confined upper tract urothelial cancer. The lymph node dissection, the lymphadenectomy improves the survival in the muscle invasive upper tract urothelial cancer, and who are not muscle invasive dissection, they having a low risk for the lymph node metastasis, so the lymph node dissection not necessary. So the who are with the patient with the imperative indications such as the solitary kidney, bilateral upper tract urothelial cancer, and the chronic kidney disease with the impaired renal function, we can consider the kidney sparing surgery. The adjuvant treatment for the followed by this surgery, the postoperative platinum-based adjuvant chemotherapy improves the disease-free survival, and the single postoperative dose of intravesical chemotherapy, the mitomycin C, 2 to 10 days after the surgery, reduces the risk of bladder tumor recurrence. And the chemotherapy, consider the chemotherapy, the patient unfit for who decline platinum-based adjuvant chemotherapy for the pathologically T3 or the N+ disease after the radical nephroureterectomy. This is the flow chart of this patient with the upper tract urothelial cancer. For the low risk cancer, for the we can consider the kidney sparing surgery with the flexible ureteroscope or segmental resection or percutaneous approach. And close finger follow-up. The high risk group, then we can give this radical nephrorectomy with the template lymphadenectomy with the open or laparoscopic approach. Patient with the muscle invasive case, we need to give the platinum-based chemotherapy. So the who are not fit for a platinum-based chemotherapy, we can consider the UroMET. So this is the flow chart of this surgical treatment of according to the location and the risk status. So metastatic upper tract urothelial cancer is a first-line setting, as all is almost same as the metastatic bladder urothelial cancer. The patient, we can divide it into the patient fit for a cisplatin-based combination chemotherapy. The who are fit, we can give the gemcitabine and the cisplatin. Patient unfit for cisplatin, but who are fit for a carboplatin, we can give the carboplatin with the gemcitabine. Then with the maintenance therapy with the avelumab, the PD-1 inhibitors. Then the patient who are unfit for the platinum-based combination therapy, that we can give the PD-L1 inhibitors, pembrolizumab and or atezolizumab. Then there are second-line settings for there are immunotherapy with the nivolumab and the novel agents with the fibroblast growth factor receptors and the antibody conjugates. And we can consider the surgery patient with the radical nephroureterectomy for the palliative patient aimed at the controlling the symptomatic disease. At the moment, there is no role in the metastectomy in management with for the metastatic urothelial cancer. The follow-up is more frequent and the stringent in patients who have undergone the kidney sparing surgery. For the after radical nephroureterectomy, for the low risk tumor, cystoscopy should be done at the 3 months, then at the 1 year, then yearly for 5 years. And the high risk tumors and the cystoscopy and the urine cytology at the 3 months, then every 3 monthly for 2 years, then every 6 months thereafter until the 5 years and then a year. The CT urography and the chest CT every 6 months for 2 years, then a year. After the kidney sparing management, the low risk tumor, cystoscopy and the CT urography at the 3 and 6 months, yearly for 5 years. And the URS at 3 months, if no second look ureteroscopy was performed. For the high risk tumor, URS and the urinary cytology at the 3 and 6 months. Thank you.
Okay, thank you, Pragalash. So we'll move to the experts for the comments.
Actually, I think it was a comprehensive presentation. The place of cystectomy is the thing. I think. Is there any place for cystectomy? You mentioned that palliative cystectomy is a possibility, isn't it?
Yes.
Yeah. And is there any place for partial cystectomy in a metastatic situation?
Yes, so when the patient presenting with the hematuria, to control the hematuria, we can consider the partial cystectomy, but it has own pros and cons because
yeah, I think there's no place. You should be brave enough to say that, because in any case, we are going to treat with chemotherapy. So I think if it is really troublesome, say, massive tumor with pain and everything, or conservative treatment is the recommended thing. And very rarely you might be able to do palliative cystectomy to get rid of the symptoms, followed by the adjuvant therapy. Partial cystectomy, there is no place.
Okay.
Any other?
Like another, what was that trial for that single intravesical installation of mitomycin after URS, upper tract tumors? You know the name?
Actually, I can't remember the trials. I take it from the EU guidelines.
It's the UroMET trial. The trial for the adjuvant chemotherapy, that's the POUT trial, as Nabil said, there's statistically significant advantage of disease-free survival and metastatic-free survival, and statistically insignificant overall survival benefit.
Yeah, and yes, I think you have to know more about checkpoint inhibitors, which are coming up in a big way. So exact mechanism of action and the availability of these drugs, because it's going to be the future most probably. And on this particular topic about metastatic, I think basically
oncologists
managed by the oncologists. So I think we enter the scene when there is ureteric obstruction, and then we have to relieve those things. And only thing is that, yeah.
Sir, may I give a case scenario? It's a short
sure.
one to discuss.
Yeah.
It's about upper tract urothelial tumors. Let's say you have a 35-year-old female and found to have left hydronephrosis, and further imaging, she has urothelial thickening at the PUJ. And then you had a doubt whether there's a lesion, and ureteroscopy has been done. There is a lesion in the PUJ, but which is not typical of urothelial. We are not sure whether it's inflammatory or a malignous neoplastic. You have taken some biopsies, and the histology shows possibility of a urothelial cancer cannot be excluded. Now, this sort of situation, what are the options available for you?
So here, sir, we can consider that we will discuss this patient with the patient regarding the option. So here we can consider that flexible ureteroscopic more biopsy, or we can consider that percutaneous biopsy. We can get the more accurate biopsy than the flexible URS.
The lesion is placed basically at the PUJ, pelviureteric junction area. Sort of a doubtful situation. Now, how will you tackle? What is the first thing you want to mention to the examiner? Basically, now don't forget about your MDT. This is something you need to discuss with your MDT or with your other colleagues. That is one. That should be the first option.
Okay.
So, as a urologist, what are the options available for you to discuss in the MDT?
Yeah, we can go with the flexor URS and the more deep biopsy, or we can consider that percutaneous biopsy for this from this lesion.
Yeah, now this sort of a case, now the chance of having a urothelial tumor is very less likely, more likely to be inflammatory lesion. This is a very common situation we may encounter. So the options would be, then you can either do an interval, maybe a surveillance ureteroscopy and have a relook, maybe take rebiopsies. That's one option. And maybe ureteroscopic washout for cytology. That's another option. And the third thing, don't forget, always you can review your histology with another pathologist. Always obtain a second opinion. That has a place. Sometimes one pathologist say it's likely, but the other one confident say very unlikely. So those are the other options available. Rather than committing, because the taking out the kidney is a major decision in a 35-year-old one without a definitive diagnosis.
And in this case, I think these repeated cytology,
yes,
cytological follow-up will be quite useful. And you should know
yes,
how to do urine cytology. Can you tell me how you will do urine cytology?
Yes,
how do you take a sample?
Yeah.
So as earlier said, so we don't need to take that early morning sample, that we need to take in the midstream sample of collecting the sample. And
yeah, what is the volume of the sample? You take it just like a MSU or a UFR, or it's different?
It's a difference. I'm not sure. So actually, I'm not aware.
Yeah, you have to take the full bladder. Okay, full bladder, the whole amount, isn't it? If it is
Full
getting
volume.
delayed, you have to keep it in the fridge, or sometimes you can use 50% formalin to preserve it if it is getting delayed. So it's a large sample. Okay, so you have to arrange it with
And
the
ideally, you should discuss with your pathologist and send it immediately for the fresh sample and assessment.
Exactly. And it should be sort of, it's in the midday, because the early morning there are debris and various things, which will mislead your diagnosis, dead tissue collections and things like that. So midday, but it has to be a full sample. So you better know these little practical points, even how to collect and interpret MSU, that is midstream sample urine. You should know. Okay, is it a spun sample or unspun sample? No, how do you what do you think? It is do you spin the urine sample before doing a UFR or not?
Sorry, sir.
Is it a sediment you check, or is it just urine sample for UFR? What you call MSU now, midstream sample of urine. Is it the high power field or low power field? You check it under microscope.
So usually high power field, sir.
How high? 200, right? 200. Otherwise, there is no specifications. You can't compare anything. Okay, and AUA always says it is cubic microliters. Coming in microliters and comes up to 5 cells per microliter. They go by microliters. So okay, fine. So this little practical points. Right. So follow up with cytology is important. As Ranga said, if it's a doubtful case, don't sort of send him home. That's the important thing.
Other things, whether you know about this grading and the interpretation of cytology, like when they give the report, they put into 5 columns. If you send a sample for cytology, that's called Paris system or something.
Yes.
Not aware or aware. So they say no adequate samples to diagnose.
Yes.
Then negative for urothelial carcinoma.
Yes.
Then atypical urothelial cells. Then suspicious high grade. And then high grade G3 or something like that.
Yes.
Malignant cells.
Yeah, you're right. Yes. I think it is very important, because even cytology, if it's a high grade, then you have to keep on looking for a primary lesion.
Sir, I would like to ask a question from the experts for the trainees' benefit. As given case scenario, the inflammatory lesion in the PUJ. So what is the place for stenting and antibiotics? before the next assessment.
Yeah, it's Ranga's case, I
Yes.
think.
No, the other thing is
Yeah.
just a comment. I just came into my mind and I asked, yes, stenting, it's an option because if it is an obstructed system, there's no doubt you need to unblock. That's one. And antibiotic, depending on your other evidence to show that there's an active infection going on. But don't forget, these patients in our part of the world, TB, that is something you need to always actively look for.
Yeah.
This is investigate for TB.
Another thing is not an uncommon reporting in CT, especially patient with PUJ obstruction and when there's a renal stone or something, the thickened upper the ureter and the pelvis suspicious of malignancy when they report in CT.
Yeah.
Frequently radiologists report like that, make our life miserable.
Yeah. And also the mimicries of upper tract tumors like malakoplakia, they just look like, you know, tumors. So those things, of course, it's a matter of repeating it after a course of antibiotics if you are suspecting infection, and look for TB, as Ranga said. Say do your PCRs and then TB cultures and things like that. Because TB comes top in the list, you know, when there's a suspicious lesion in a young person.
Another thing as a trainee is if you get a something like that, which is not obvious in the literature, you should be able to tell the pros and cons and everything rather than come to a conclusion in front of the examiner. And that is, you should show your maturity that, like Ranga said about the MDTs and other options and what you think and all these things, rather than directly say I will directly jump to a specific treatment, because nobody can say exact answer for this type of thing.
A little bit about the embolization now to prevent bleeding from the bladder, the advanced tumor bleeding from the bladder. So how will you perform embolization? Anything, any practical points? Arteries will you embolize?
Internal iliac artery. So we can use it the coiling or the gel for that.
Yes, because the inferior, superior, the vesical arteries and embolization specifically will not work because the bladder will have a very, very rich supply. And even if you block one, and it will bleed from the others. So usually it has to be internal iliac.
And according to the radiologist, because we got a case, because I have not studied in depth, but he said that they block the main artery than branches because the risk of bladder devascularization is more with if they go for a specific small old artery. I don't know exactly, but what he said.
As long as the superior gluteals are there,
yeah.
Superior gluteals are there is a rich anastomosis.
Yes.
Never ever seen a bladder necrosis. So, but the blood bleeding, as Ranga said, will not stop if you do a selective embolization. So you go for the stem. The good old days, we used to just open and quickly tie the stem of the internal iliac, which will stop any kind of, you know, bleeding.
Only issue I would say, sir, because if you are worried about a patient with erectile dysfunction in a male patient, then there's a concern. But here it's a balanced risk versus benefit in a bleeding patient.
How we plan to proceed, Nishanta? Now,
I think almost time is up.
Yeah.
Sir, if you want, I mean, we can discuss one or two questions on non-muscle invasive, sir. I mean,
right. Nishanta, so can I ask the trainees about the muscle invasive bladder cancer? What are the clues that you get in your assessment to say that it's a muscle invasive? Obviously, we confirm it by after the TURBT. Before that, how can we say what are the clues you get? It's a muscle invasive bladder.
Trainees, I think we'll direct to Prasanna first.
Yeah, Prasanna, yes.
Yeah, Prasanna.
Okay. Yeah.
Prasanna, are you there?
Yes. One is, sir, first imaging. We can, if we do the preoperative imaging, TURBT, there's a chance. Then other one is the after general anesthesia. We can do the after general anesthesia, sir. We can do the bimanual examination. With the bimanual examination, there's a chance we can assess the muscle invasiveness, but I think around 30% of time. Otherwise, we can't sure about the invasiveness with the bimanual alone.
Right.
And the other thing is imaging, sir.
Yeah, the imaging you need to specify. Now, number one, usually most of these patients they will end up with a first ultrasound scan. If the ultrasound scan or whatever the imaging, if it shows hydronephrosis in the presence of a bladder tumor, it's unless proven otherwise, it's muscle invasive. That's number one. Number two, what is the best imaging modality to show the muscle invasiveness? What do you think? Now, commonly we perform CT urogram. Do you think the CT urogram is good enough to say it's muscle invasive, or any other investigation?
Multiparametric MRI, but EAU guideline doesn't they didn't recommend the multiparametric MRI for muscle to assess the muscle
because there is a comparative study
point,
between CT and MRI. Though theoretically MRI can show the depth, the final outcome of that study shows that there is no difference in staging when it comes to staging. So because of that, MRI is preferred if there are contraindications for CT, like contrast allergy and things like that. So otherwise,
and the other thing, yes, the other thing, the CT urogram, if you do before the TURBT, which should be the ideal case, and then if it shows perivesical fat stranding, thickening and things, then those are the other indicators to show that probably it's a muscle invasive. But of course, if it is following TURBT, because of our limitation in our setup, then you can't comment because the post-surgical artifacts will come into play.
That's very true. Because I think, once it is diagnosed, I think the best thing is to do the CT first before you go for TURBT, because resectional artifacts are sometimes very misleading. So, or else you wait for about 3 weeks, 2 to 3 weeks for edema and everything to settle, and then go for a CT if you are doing it post TURBT.
Whatever it is, the final decision is basically based on your TURBT specimen histology confirmation.
Yes. And I think somebody during his discussion said that very superficial tumors like pun lumps or papilloma, these TAs, you can, what was he telling? Yeah. Even if the muscle layer is not there, you will not do a redo resection. Though the guidelines say that, be little cautious about it, because it may be just a incomplete resection. So if the muscle is not available, I think always ask for resampling, because they don't sample the whole tumor. So ask for resampling or go for a resection rather than ignoring it. Because guidelines, some of the EUA guidelines say that if it's a very superficial tumor, not to go for only T1, to go for redo or restaging resection. And you can avoid redo resection in superficial ones. But in our setup, I think either you ask for resampling or go for a redo for all TA and T1s. I think that's...
And what percentages of tumor percentage will have the upstage after re-resection? Any idea? Now, initially, non-muscle invasive tumor, you subject them to a re-resection. And what percentage of patients will have the upstaging to indicate that it's a muscle invasive tumor?
Those are the exam questions, right?
Yes. Any answers? Any guesses?
It's high, low, very high. Yeah.
Yes.
20% around?
Yeah, you are somewhere there. Yes. 20 to 25% will have a muscle invasive disease. Overall, it's variable again between series. Anything to add?
Yeah, again, T1. If it is a G, say as grading, if it is G2 or G3, even there's 35 to 40% chance that there will be muscle invasion. Because T1 is generally non-muscle invasive, considered non-muscle invasive. So if you have T1, G2, G3, always go for a resection, and you will find that about 30 to 35% of them have upgrading into a T2, T2A or T2B. So those are the percentages given.
Yeah, the other thing now, young patients with muscle invasive tumor, anything you know about the trimodal therapy and the bladder preservation? That is something we need to know.
Yes, those who are not fit enough for the cystectomy, then we can think about the intravesical treatment. Then
that's one category. That's one category. And also you need to think about now it's a new theory because always the native bladder has a better quality of life. So if you can keep the patient under strict surveillance and a reliable patient, and then there is a place, isn't it, sir?
Yeah, that's right. Because all these studies of trimodal therapy were done when the chemotherapy was the sort of the extreme of the hallmark of the trimodal radiation. But when these checkpoint inhibitors and immunotherapy came up in a big way, now the oncologists are up in arms, saying that trimodal therapy and bladder preservation is becoming more and more possible because their response to PD-1s and all these checkpoint CPIs are much better than chemotherapy. So in future, the trials are still on. So with those in place of chemotherapy, there may be a better place for small volume tumors. I would say the volume and the multifocalness makes a big difference, and also presence of high grade PIN. So those factors, when you exclude, I think the small volume tumors, there will be a place for bladder preservation.
Yeah, quite correct. So now there are 3 other clinical parameters where you used to identify the risk to classify, that is patient's age and then the tumor size, whether it's more than or less than 3 centimeter, and the multifocality. Yeah. Those are the other 3 factors in addition to the pathological factors you consider when you categorize them.
That's right. Yes. Yes.
Other thing is a tumor in the diverticulum.
Yeah.
Ah, yes.
What could be the
That's a nightmare.
Nightmare.
Yeah. I think this is bladder tumor being a grade based or grade based tumor. I think if it's a low grade tumor, there may be a place for a partial cystectomy with trimodal therapy. But if it's a high grade, I think I am very particular about the grade G2, G3. That's bad news. So go for a cystectomy rather than anything else. And regarding cystectomies, again, any idea about trainee has any idea about the lymph node dissection and the importance of the lymph node dissection?
Yeah, we'll change the candidate to Pagaladan. Pagaladan? Yep. Is Pagaladan there?
Yes, sir.
Okay.
You have to take the burden of Tivika now. I think she has put you all into trouble and gone for the conference. So better face the firing squad now. Right? Okay, yeah. What is the place of lymph node resection in?
So lymph node dissection in the radical cystectomy, it's having in the survival improvements.
Yeah.
Minimum of at least 12 to 14 lymph nodes we need to retrieve for the accurate staging as well as.
Yeah. What are types of lymph node levels? Are there any levels of resection? No. Just very standard. Standard resection and extended and super extended. So how do you decide the level? If it is in the true pelvis, it is standard resection. If it is, yeah. So read about it, the level of. So is there any advantage of going up to super extended resection?
It's actually containing the more morbidity to the patient. So not that significant improvement in the survival. So I'm not sure actually that.
Yeah, I think again the audience is split. I think in that case, with the super extended, that is going above the pelvis and resecting it has an advantage. But more the number of lymph nodes is better. Minimum number of lymph nodes is how much? Given in guidelines, 10 has to be there. Otherwise, your lymph node dissection is not complete. Okay, 10, more the merrier, And technical point wise, which part of the lymph nodes I think you should leave to prevent lower limb edema? But that is one of the problems you might encounter if you get rid of the whole bunch of lymph nodes from the pelvis. Lateral to the artery, those lymphatics and tissues, you try your best to sort of prevent, leave it. Because if you go lateral to the artery, then there is a higher chance of lower lymphedema. But in between the vein and the artery, plus whatever along the obturator and the pelvis, you have to get rid of. So, any other questions?
We need to send the lymph node in separate samples to increase the yield.
Yes, yes, that's right. And positive lymph node state, does it change the management, further management? Suppose lymph nodes are negative and lymph nodes are positive. So does it make any difference to the adjuvant treatment?
Yes, the positive lymph node status where we need to add that platinum based or the nivolumab, that other drugs should be given for the adjuvant treatment.
Yeah. So what is the chemotherapy regime you mentioned?
Platinum based.
It is a very wide based answer. So I want to tell MVAC is one. That's the older one. Then PCG. PCG is the new one. PCG is paclitaxel, gemcitabine, and
cisplatin.
Cisplatin, yes. So PCG and nivolumab, adalimumab, all the whole thing comes after this. So chemotherapy will be essential, if the lymph nodes are positive, because you can never get rid of the whole lot. And regarding cystectomy and cystectomy types, I think we are this is an interesting subject for all of us, so we might go on till this morning. What is best? You said about if you take what are types of cystectomies, radical cystectomy technique-wise, open
and the robotic and the laparoscopic techniques.
Laparoscopic techniques. So is there any advantage? Yeah.
Actually, the overall survival was equal to the doing it open and the robotic and laparoscopic.
Yes. Are there any studies going on, ongoing studies?
Studies are going
on. Yeah, opera study. Read about opera study. The outcome has not come yet. That is open versus robotic or laparoscopy, robotic assisted cystectomy. It's ongoing. It's a fairly large study. So waiting for the final result to come. Opera study, right? So that will give us the answer. But first you have to get a robot to get involved in robotic resection. So master the open technique for the time being. Any other?
The other thing now, urinary diversion versus neobladders. What are the contraindications for orthotopic neobladders in a patient with muscle invasive bladder tube? How will you decide? How will you guide the patient whether to go ahead with the neobladder or not to go ahead with the neobladder? What are the factors you take into consideration?
What are the contraindications for a neobladder? But neobladder is a very suitable option for this type of, in our part of the world, rather than going for a ileal conduit, which is the commonest way of urinary diversion. 75% of diversions are still done as ileal conduits. But what are the contraindications for a neobladder, forming a neobladder? Can you think about anything? Just the common sense?
Taking the ileal conduits is contraindication, then we can do like inflammatory bowel disease or distal ileal, those diseases. And then we can think about whether it is orthotopic or heterotopic neobladder formation. If the sphincter complex is damaged, then we have to think about the heterotopic neobladder formation.
Yes.
And the other thing, the presence of the tumor at the trigonal area. That's a clear contraindication, because if the trigone is involved, particularly the bladder and neck area with the tumor, then the neobladders are contraindicated.
And other thing is the patient's renal function.
Yes.
You're right.
That's what we think
Correct.
of.
Yes.
And obviously, if you have a patient who's marginally fit for a major surgery, now if you are taking them through a neobladder, that will adapt to your anesthetic time. So if you want to finish early and very short anesthesia time, maybe you consider elderly people with comorbidity, you consider ileal conduit than a neobladder. That's a relative factor that you would consider with your anesthetist.
So basically, need to think of cancer factor, bowel factor, and general factor.
General factors, yes.
That's right.
And always have open discussion. You can say that you need to discuss with your colleagues, the anesthetist, and particularly when you are selecting the patient. The patient selection is very important.
Yeah.
In which patient you will consider radical cystectomy over radiotherapy?
It's a question to the
Trainees.
candidates. So, yeah. Yeah. Up to now, you are comparing radiotherapy versus radical cystectomy for muscle invasive. My BC? Yeah, there are no RCTs up to now, which shows that one is better than the other. They both have their pros and cons. But then there is one study, I think a large study, which one old study to show that radical cystectomy, the tumor-free survival and overall survival is about double the radiotherapy. That's one of the old studies. I can't remember the exact.
What is the counter argument for this study? Now, this study shows the radical cystectomy is slightly better.
Yeah.
One of the oldest studies.
Because
there's always a counter argument by the oncologist.
Yes. They say that you select the older and weaker people for radiotherapy and take the fitter and young chaps for radical cystectomy, so that automatically the outcome is going to be better. So
they say there's a bias. Yes.
Yeah, bias. Yes, surgeon bias.
Other thing,
selection bias.
We should not give radiotherapy to downgrade the tumor if you are planning for radical.
Oh, yes.
Yeah, this is chemo.
Yeah,
yes.
Chemo is a must now.
What is the survival benefit overall by giving neoadjuvant chemotherapy before cystectomy? Any idea?
5%.
5 to 7.
5 to 8%.
It's very, very disappointing. But by default, we don't send them. But then when we look at this figure, we feel happy that we are not sending it.
It's a 5 to 8%.
It's a 5 to 10%, isn't it?
Yeah, 5 to 8%.
Very low. Yeah,
very low.
So, but anyway, all guidelines for trainees, all guidelines, neoadjuvant chemotherapy has become a standard of care now. So just remember that. So the practical world and the theoretical world.
And the other thing, by recommendation, all the guidelines, they say not to delay your cystectomy more than a month from the time that you decide on it, just because you want to plan some other things and all, then the tumor progression is higher.
Right. That's called 30-day rule, and then you can be, there could be a litigation.
Yes.
In other countries, if you violate this 30-day rule after diagnosis.
And other thing that you have to tell the patient that because depend on your completeness of the resection initial, the final histology may be negative if you do radical cystectomy, because if you completely resect
correct
with a good TURBT, because at the end when the patient comes for your consultation with you with the histology report, he says, why did you remove my bladder? Because no tumor in my bladder now. And you have to inform.
You're right. And after the first URBT, before deciding it, in this type of tricky cases, I have come across, nearly fell into the trap. You, after resecting it completely, and if it is a T2A or something like that, before even T8 or T2B, always go for another CT or a cystoscopy. I have come across number of times, there is hardly any tumor seen, not even a scar, and the CT says it's normal. Though the histology suggests that it's a muscle invasive cancer. So I'm very happy that Manjula mentioned that is a trap you should not fall into.
And other things, what is your experience about this resection positive histology, muscle-based resection? How frequently you get?
You mean redo resection?
Yeah.
Unfortunately, our positivity rates, though the book says that it's about 30%, becoming positive. My experience, of course, that positivity rate is not that high.
Yeah.
I don't know whether others share my feeling. Because when you do, probably we are doing a very sort of good resection up to the deep muscle. Maybe our resection is good. Re-resection rates are not that high as it is given in books.
And
what is your experience? Yeah.
I never, I mean, none of my resection, I never found any of the positive cases.
Exactly, very low resection. What do you think about it, Ranga?
Yes, quite correct, sir. In our series, it's quite less.
Yes.
Other thing, especially female resection, so their muscle layer almost not there in some area. So you have to be very careful. You might perforate the bladder, especially when you resect in the bladder, I mean the trigone area where you easily make a VVF.
Yes, the trick for that is not to allow the bladder to get overfilled. Keep it always partially filled and collapsed when you are resecting the tumor in elderly women, because their bladders, as you said, are paper thin. So
yeah, only
very easily you can
mucosa.
perforate. Yeah, only the mucosa. So if you distend it and cut, so definitely you will make a hole there.
Another thing they say is if there's especially after initial resection for the primary tumor, which is seems to be low grade non-invasive, if there's a perforation or something, and if you can't give mitomycin, they ask better to irrigate it, because that is also help in certain extent.
Yeah, it's called barbotage. Yes. Only it is irrigation. Yes, continuous irrigation, isn't it? Yes. Yes. But forceful irrigation, I think, will be a bit of a problem if it is a perforation, isn't it?
Yeah.
Yes.
But
sir, I just to mention, so since we are discussing about the irrigation now, earlier there was a question about contraindications for intravesical chemo. One is persistent hematuria after TURBT, also a relative contraindication for you to proceed with immediate postoperative chemotherapy for the bladder.
Yes, and also infection, isn't it? If there are signs of infection, cystitis, and positive culture, you're not supposed to do that. And also perforation, signs of perforation.
Can I ask from the trainees, can we offer BCG immediately after TURBT? Like we offer MMC, mitomycin, chemotherapy, can we offer intravesical BCG immediately after TURBT? Any thoughts about it? Yes or no? If yes, the advantages, no, the reasons.
No, sir.
Why? What is the reason?
Reason because we can inoculate through the circulatory system, and other hemogeneous spread will be there. The BCG.
Yeah, what is the dreadful complication, the most fearful complication in these patients if you give BCG?
Anaphylactic reactions when
not really, and you are more worried about the fulminant hepatic failure. They can have a very bad hepatic reaction, liver failure. That is the main concern.
What is the waiting time then?
Yes.
Ideally, we have to wait at least 2 to 4 weeks after complete the resolvement of the part of the resection to give at least for a 2 week, at least 2 weeks. Minimum 2 weeks, 2 to 6 weeks, we consider it as a therapeutic duration. The initial start of the BCG.
And other thing you need to know about the BCG refractory, BCG relapse, BCG non-responsive, and BCG intolerance. The wordings, in certain extent, you have to do some explanation on these topics if the examiners.
Yeah, because if you take BCG failure, that will include those three. That is refractory, relapsing, and non-responsive. Those three is covered by the term BCG failure.
Yeah. Do you know the action of BCG? How does it act, and what is BCG? Is it human BCG or something else? Bacillus of Calmette and Guerin, is it human or not?
Human
it is bovine. Okay.
Bovine,
it's not tuberculosis. It is not Mycobacterium tuberculosis. Bovis. Okay.
Yes.
Yeah. And how does it act? Does it destroy the normal urothelium as well, or it is only the tumor cells?
mainly tumor cells, where it is type 4 mediated immunity, where it's a slow reaction and immune mediated T.
Yes, how does it do that?
It will antigen go and bind, and this BCG is reacting the immune cells, where the T8 cells, the cytotoxic T cells, where the role play comes.
It gets attached to the urothelium, the fibronectin protein of urothelial cells first. But there are positive and negative charges on these bacteria and the cell surface. So what happens is there are more positive and negative charges in tumor cells, but normal cells, negative charges. So it doesn't get attached that strongly to the normal urothelium. So that's why it escaped. So only the tumor cells absorb the bacillus and make this urothelium antigenic. So that is one theory. There are all theories. Nobody knows exactly how it acts. Better know that, because sometimes you never know. They might ask how exactly it acts. Okay. So the mechanism of action on normal urothelium and the tumor urothelium is tumor cell is different when it comes to the BCG. And the BCG strains are also there. They're all the same. You know the names? Yeah, just read about it. Conort and TICE and various things are there, but the action is more or less same. Okay.
Nabil, what are the advices you will give to a patient on BCG?
Yes. This treatment before starting, it has to be for the completion. We have to ask for this has to be given in the induction and sometimes maintenance continuously, and you have to follow this. Other things, the side effects mainly we have discussed about the recurrent. Sometimes patient will have cystitis features and the increased frequency and urgency, these symptoms, and a long-term run it can cause a bladder fibrosis, even low capacity bladder. Those things, functional capacity will be low. So those things has to be discussed regarding this BCG, and there is a rare possibility we can cause that genitourinary or systemic tuberculosis. Very rare possibility.
Yeah, suppose he get a UTI during BCG therapy.
Yes.
What antibiotics will you give? And better if I ask, what will you not give? Antibiotics.
Yeah, as usually ciprofloxacin.
Yeah, why is that?
So it can use as second line therapy for a TB.
Yeah, it's a DNA gyrase inhibitor. So it's a second line TB, anti-TB. So it nullifies the action. So yeah.
And you have to tell the patient to sit to urinate, otherwise he will splash urine, and then hand washing, flushing of common with bleach, and then if there is more residual volume, we might need to use catheter to drain the urine. There is more residual volume, and avoid sex for a couple of days.
Right. Yeah, that's right.
Any other things, sir? Mandira, sir?
Can I just ask for my information, sir? There is a theory going on. Most of the oncologists, they talk about this. When you are catheterizing a patient before BCG, not to use lignocaine gel. Is there a real benefit or any scientific value? Have you heard about anything? Ever come across something like this?
No, I think catheter trauma will prevent the BCG installation.
Exactly.
So if you have any type of hematuria or bleeding PU during catheterization, so to avoid that, I think some sort of a bland jelly at least you need. Lignocaine and BCG, I have not come across anything. Have the others come across anything like that, or because directly lignocaine and BCG, I'm not quite sure if there's an interaction or anything. So are they sort of very particular about it? They might have heard it
Some-
from one of these.
Some of the oncologists, they are very particular, sir. I'm not sure whether there's a scientific basis.
Maybe because I don't know, I'm not aware about that, but maybe some lignocaine may go and lodge in the trigone and that area may not expose to BCG or something. Yeah, but it's
But
not.
then okay, you put the solution for 2 hours, no? 2 hours,
Yeah.
and that is the time for aqueous thing to. I think you must ask the fellows who are asking for it to give a reason. That they might have picked up something, from one of their conferences or discussions or something like that. That's why they are particular, eh? I have not come across anything like that.
Right. Okay, sir.
But
And any other thing, I think they need to know about some sexual preserving cystectomies like prostate and prostatic capsule preserving, seminal vesicle preserving, and nerve sparing. Just some wordings that.
Yeah.
Somebody
So you can mention everything and say that none is recommended here. And the guidelines will all reject it. If you go to the guidelines, they will reject it all. These are all at experimental level. Ultimately, they will mention about it. This seminal vesicle pairing. Sometimes it's very tempting to leave the prostate and come out. Because when there's a bladder dome tumor, you feel like, leaving a little bit of prostate there. So it's easy for you to do a neobladder and fix it. But what is the percentage of prostate cancers you find when you do cystoprostatectomies? That is another question they ask. Now you do incidental prostate cancer after cystoprostatectomy.
25%?
Yeah, 25 to 35%. Amazingly high, but I don't think I have come across even 5 during my lifetime. But if you go through the literature, it's a fairly high thing, and then they are not quite sure about the guidelines, what to do with that. If it becomes positive, how to follow it. So already you have done a radical prostatectomy. So what they say with the PSA follow-up. Yeah.
Maybe they do more elderly people, radical cystectomy in more elderly people.
Yeah, I think so. Yeah, their figures are very high. We have gone through all these cystectomy specimens. We hardly ever come, I don't know, Ranga and Nishant, have you all come across Taha?
No.
Very few, no?
Yeah. I heard that about up to 40% they can have positive the prostate
Exactly.
cancer, but
Exactly. Either our fellows are not sectioning the prostate.
Yeah. I have a couple of patients who are having both prostate and bladder tumors at the same time, but they have not undergone any cystectomy.
That's right. So these are incidental findings, incidental prostate cancer found in cystoprostatectomy specimens. Very high figures they give it in literature. So, so because of that, I think these partial type of resections, I think, I don't know what is Manjula's opinion about it. They are mentioned, and ultimately the last sentence will say that they are not to be done other than in highly specialized centers.
I mean, so, just to have some idea, not.
Yeah, sure. Yeah, I agree. I think they should know about it. Yeah. I mean, somebody keeps on asking, can you preserve the prostate? Can you preserve the thing? You must answer saying that, those are there.
And when you answer in those things, then you have to tell about the compromisation of the oncological principles and things is possible and etc. Rather than just telling straight away.
Yeah, rejecting it, isn't it? Yeah.
Or accepting it.
And also having incidental prostate cancer is also, I think, probably you can put it as a argument.
And then you have to know about the anastomosis techniques to the ileal conduit and that they might ask. And the long run complication of this uretero neobladder anastomosis and the uretero conduit anastomosis, because they have, with long run, they can get ischemic type of strictures at the anastomotic site and stones and metabolic complications and all these things they might ask.
Yes. And
there is that high incidence of prostate cancer. There was a question that if a patient comes with hematuria and a scan report of bladder tumor, whether we want to do a PSA in that patient.
I think these only nice guidelines and Baus says that to go and do a PSA. I'm not quite sure about the other guidelines. Other guidelines, they don't do PSA for hematuria unless there is a clinical suspicion or there is a high, there's a strong family history and there are other risk factors. They don't include routine PSA in hematuria investigations. But nice guidelines, the lower part of it says just that to do a PSA. Because unless it's advanced prostate cancer, very unlikely that it will cause hematuria. Because in advanced stages only, it invades the prostatic urethra or the trigone. So even theoretically,
If
I
he
think
comes
it will be,
with
yeah.
if he comes with a scan report of bladder tumor also, sir?
If there's a scan report of bladder tumor,
Yes, and hematuria, whether we want to do a PSA, because high incidence of incidental prostate cancer in cystic prostatectomy.
oh yes. Yeah, same argument, isn't it? Yes, I suppose, yeah, there is a place, but not to look for a cause for hematuria, no? In that case, because unless it's a very advanced prostate cancer, that wouldn't cause hematuria. But because of this high incidence of incidental prostate cancer, you might be able to justify doing a PSA.
So I don't know the guidelines, but in very selectively I practice, particularly if you see a ultrasound scan, a lesion, mass lesion in continuity with the prostate, where you suspect a prostate cancer invading the bladder, probably yes. Probably yes.
Trigonal, low trigonal and prostate masses, PSA is a must, because we have fallen into this trap, no? This prostate cancer eating into the bladder.
They say it's a bladder tumor, but when you go in, it's an extension of the prostate.
Extension of the prostate tumor. Very true. Very
true. Okay, sir. I think we didn't realize, with the interest of discussion, we didn't realize that we have passed the time.
Yes, half of the audience has gone to sleep, I think.
Nearly half, yes.
Yes.
It was a nice session with good talks and nice discussion with expert panels with the experience. I learned a lot. I would thank SLAU's academic committee headed by Anuruddha sir, and then the presenters, Dr. Nabil, Prasanna, as well as Pragalatan, and of course expertise, Navil sir, Manjula sir, Ranga sir, with their, among their busy schedule, they have come here. They have shared their knowledge and experience. Thank you very much, sir. And I would like to thank my co-moderator, Nishanta Veerasinghe. And then the last, not for the least, I would like to thank the organizers, CIPLA, for organizing this. Hope you have all enjoyed. Actually, I enjoyed the session. You have enjoyed the session, and we will meet you next week, probably prostate cancer 1, and we will update the senior registrars regarding the schedule. Thank you very much, everyone.
Thank you.
Good evening and a nice weekend.
Thank you, sir.
Thanks, Taha. Thanks for organizing.
Thank you,
sir. Good night. Yes.
Good night.
Thank you.
Thank you.